Hello, my name is Dr. Bill Gray. I'm the System Chief of Cardiovascular Division at Mainline Health, just outside Philadelphia. I'm an interventional cardiologist, been involved with carotid interventions for over 25 years, and I was privileged to be the national and global PI, along with Rolf Longhoff, for the Performance 2 study, which we'll be talking about today. The Performance 2 study is an important trial specifically because, first of all, it's the first trial in almost a decade using a new technology in carotid stenting. Equally important is that it introduces a new concept in carotid stenting, which is augmented cerebral embolic protection. As most people know, the most likely time for embolic release is during the post-stent balloon inflation. And that has, I think, been a little bit of a nettle in the larger field of carotid stenting, and has led to observations largely related to DWI abnormalities, which are generally asymptomatic but excessive in carotid stenting as compared to, let's say, endarterectomy, but also a small excess of minor strokes, which we think are probably correlated with these increases in DWI abnormalities. The trials that led up to Performance 2 suggested that double filtration, and I'll talk about the filter in a minute, led to reduced DWI abnormalities on par with endarterectomy, and that the filters, when analyzed after the procedure, were capturing materials that were, in 90% of the cases, less than 120 microns or 100 microns in nature. Now, that's important because the current filters that we use in the distal embolic protection arena usually have pore sizes of about 100 to 120. So what we're saying here is that the filter with the Neuroguard protection system, which has 40 micron filters, pores, was capturing 90% of material that might have otherwise gotten through our current filters. And it's this level of not only double filtration, but improved or augmented filtration, which I think carries the promise of a reduced overall clinical event rate. The Neuroguard IEP system, IEP stands for Integrated Embolic Protection, is actually not just unique in the sense that it adds to the embolic protection, but it also is a combined device which allows for rapid carotid stenting without multiple catheter exchanges. So the device is set up such that there is a 6 French system. The distal part of that system has an integrated filter, which is remotely actuated from the proximal handle by the operator when the device is in place. That device, that filter is then more proximally arranged with a self-expanding closed cell stent, which is purpose-built for carotid stenting and has a lot of flexibility, even though it's a closed cell stent. So the pore size is reduced, and yet it maintains flexibility. And that has allowed, and then that is mounted on top of a balloon, a 5 millimeter balloon, which is used to inflate after after stent deployment. So the way the device is used is you slide it up, you put your standard embolic protection system distally in the internal carotid artery near the petrous segment. You slide this device up over the wire. You deploy the filter after pulling back the sheet that constrains it. Deploy the filter until you have full wall apposition. You can tell that because there's markers on the filter that help you understand that. And then you slide the sheath back some more, deploy the stent, and then inflate the balloon, post-dilate the stent, to take the filter down, pull it out, and you're done. Then you just have to take out your distal embolic protection system. So it's a very efficient, both from a number of maneuvers and time efficient standpoint, as well as augmenting embolic protection like we discussed earlier. The Performance 2 trial was actually a follow-on from the Performance 1 trial, which was done in Europe. This was a 67-patient trial, which had excellent results, no strokes, no deaths, no myocardial infarction at the 30-day interval. And based on these encouraging trial results from Performance 1, Performance 2 was constructed as a pivotal approval trial for FDA clearance and approval. So the Performance 2 trial is a fairly typical high surgical risk carotid stenosis trial. Patients had to have significant comorbid conditions, either anatomic or comorbid, that would make them high risk for surgery. The trial had 305 patients enrolled in 40 sites around the world. As I mentioned before, Rolf Langhoff was my global co-PI. If you had a symptomatic stenosis, it had to be more than 50% in severity, and an asymptomatic stenosis had to be more than 80% in severity. And by FDA mandate, we had to have at least 20% of the patients who were symptomatic. There was a screening committee which enforce the inclusion and exclusion criteria. They weren't meant to cherry pick patients, but really meant to make certain that the patients were qualified per the pre-specified inclusion exclusion criteria, which really largely revolved around anatomic exclusions related to excessive calcification, excessive tortuosity, either in the distal vessel, the approach vessels, or unfavorable aortic arches, either due to excessive disease or type 3 arches. So that's the construct of the trial. It's, again, fairly similar to most of the high-risk carotid trials that have come before it. The outcomes of the trial, it was a single-arm trial, were going to be compared to a pre-specified performance goal that was pre-established by the FDA and the sponsor. Well, the results were quite pleasing. So if we look strictly at stroke, which is really what we want to understand here, we had no major strokes in any of the 305 patients. There were 4 minor strokes, all of which recovered by 30 days, one of which was off protocol from a clinical perspective. The patient had a hypercoagulable state, should never have been enrolled in the trial. So if we look at the per protocol analysis of the trial, there was less than 1% rate of stroke and no major strokes. So very pleasing event rates. There was 1 death unrelated to the device or procedure, and a couple of MIs, again, unrelated to the device or procedure. So overall, as you look at it from the context of what's come before Performance 2, it was, for any prospective trial, the lowest rate of stroke ever reported in the kind of pantheon of trial results. In addition to the excellent 30-day results, we saw both 1 and 2-year results, which were outstanding. There were no major strokes at 1 year from the 30-day mark to 1 year. There was 1 minor stroke, which occurred unrelated to the device and with the patent stent. And there was no clinically driven target lesion revascularizations at 1 year, which is a testimony to the durability of this purpose-built stent. At 2 years, again, we have no new neurologic events and very low rates of clinically driven TLR. So I take away from this trial that using a new technology, both a purpose-built stent as well as a kind of ultrafiltration 40-micron filter in concert with existing filter protection technology, that we can reduce the rates of stroke in carotid stenting to at least be on par with, if not better than, anything that's come before, which includes TCAR, endarterectomy, and prior stents. And what that means is we're now, in the 1% range of stroke, we're now in the same range that we use to talk about PFO closure, left atrial appendage closure, other stroke preventative therapies that we use to help patients reduce their overall adverse event outcomes. As you probably know, there have been additional technologies introduced over the last decade or so using transcarotid arterial revascularization, or TCAR. And it'll be very interesting to see using TCAR approaches, which is a surgical incision here and a direct surgical access with sheath and flow reversal as a primary embolic protection mechanism, using that technology along with the Neuroguard IEP, it'll be interesting to see what the combination of that therapy holds for our patients. And that trial is actually already underway.